When you are sitting at the desk on a busy floor and a serum sodium result pops up back from the lab at 122, your brain needs to immediately, and I mean immediately, put that client at the very top of your priority list. Sodium is not just another box on a basic metabolic panel. When serum sodium strays outside that normal narrow range of 135 to 145 milliequivalents per liter, the brain is the ultimate organ on the clock. Why? Because water follows sodium, always. When sodium concentration shifts rapidly in the fluid surrounding cells, sudden osmotic shifts force brain cells to either swell up like overfilled sponges or shrink down like tiny raisins. Let us break down what is actually happening in the tissue. In hyponatremia, where serum sodium drops below 135, the extracellular fluid becomes dangerously diluted. So by osmosis, water rushes out of the diluted blood into the higher solute concentration inside the brain cells, driving acute cerebral edema. You see acute lethargy, sudden confusion, headache, and a massive jump in seizure risk. Now compare that to hypernatremia, where sodium climbs above 145 milliequivalents per liter. Here, elevated serum sodium levels cause the osmotic movement of water out of the cells to dilute the blood. The hypertonic fluid actively pulls water out of brain cells, shrinking them. The client gets intensely thirsty, restless, agitated, and you will notice sticky, dry mucous membranes when you check their mouth. Let's imagine you are going to assess Mrs. Smith in room 412, who is just getting a little more confused today. You may think it is probably just her baseline dementia acting up or sundowning. But wait, let us stop right there and reevaluate. Have you checked her basic metabolic panel from this morning? We pull up the chart and boom, her sodium is sitting at 122 milliequivalents per liter. That is not baseline dementia. That is an acute neurological red flag caused by severe hyponatremia. The moment you restore that fluid balance or recognize the drop, you literally save that client from progressing to seizures or a coma. But here is the critical part, the speed limit on fixing these numbers. You cannot just blast fluid into these clients to fix the laboratory value overnight. If a client has hypernatremia and you rehydrate them way too fast, using hypotonic intravenous fluids like 0.45% normal saline or 5% dextrose in water, you cause a sudden shift of fluid rushing straight back into dried out brain cells, causing acute, fatal brain swelling. On the flip side, if you overcorrect chronic hyponatremia too fast by pushing sodium up rapidly, you risk osmotic demyelination syndrome, which causes irreversible neurological damage. Slow, steady, guarded correction is the rule every single time. Now, a sodium laboratory value sitting by itself on a piece of paper or a computer screen only gives you half the story. A sodium level of 128 tells you the concentration is low, but it tells you absolutely nothing about the client's overall volume status. You have to put your hands on the client and unmask their actual fluid volume state. For example, if a client has hypovolemic hyponatremia, meaning they lost both water and sodium through heavy vomiting, diarrhea, or overzealous diuretic use, they are dried out. You are going to see poor skin turgor, dry mucous membranes, tachycardia, and orthostatic hypotension when they sit up on the edge of the bed. Contrast that with hypervolemic hyponatremia. That is your client with chronic heart failure, liver cirrhosis, or end-stage kidney disease. The sodium is low because it is completely diluted by massive fluid retention. When you walk into that room, you do not see poor skin turgor. You see 3+ pitting edema in the lower extremities, jugular venous distension, crackles in the lungs, and a rapid gain in daily body weight. Same low sodium number on the lab sheet, but two completely opposite clinical presentations requiring entirely different nursing care. While you are assessing the physical presentation, you also need to look at how the kidneys are trying to compensate. Urine metrics give us a direct window into renal compensation. If a client is in a severe fluid volume deficit, the kidneys will do everything in their power to conserve water. You will see oliguria, defined as urine output dropping below 30 milliliters per hour, or less than 0.5 milliliters per kilogram per hour. And when you check the urine lab values, you will see a high urine-specific gravity above 1.030 and an elevated urine osmolality, confirming that the kidneys are concentrating the urine to hold on to every precious drop of water. Putting all of this into practice means solid nursing interventions and clear, compassionate client teaching. When caring for a client on a fluid restriction for hypervolemic hyponatremia, say restricted to 1,000 to 1,500 milliliters per day, you have to help them structure that allowance. Do not let them drink all 1,500 milliliters by noon. Divide it up, save half for meals, and keep ice chips handy to manage dry mouth without breaking the fluid limit. For our clients with hypernatremia, client education revolves around tracking daily weights at home, using the same scale every morning right after their first void, wearing similar clothing, and reporting a gain or loss of 2 to 3 pounds in a day. And do not forget to teach them about hidden sources of dietary sodium. It is not just about putting down the salt shaker at the dinner table. High levels of sodium hide in canned soups, processed meats, frozen dinners, and even over-the-counter antacids that clients pop like candy for heartburn. As nurses, when we bridge the gap between underlying pathophysiology, careful physical assessment, and practical client education, we keep our clients safe and stabilize homeostatic balance before a crisis ever starts. Keep an eye on those sodium labs, watch your urine metrics, and I will see you next time.